Well, hello and welcome to another edition of Health Solutions with Shawn and Janet Needham, where Team Needham discusses everything healthcare. I am your host, Shawn Needham, along with my wonderful wife, Janet, and our producer, Lindsay, and we are streaming from the Moses Lake Professional Pharmacy studio today. And today we have Dr. Daniel Bahnmiller on. He is a OBGYN doctor in Tricities at Columbia Shores OBGYN, and you do not want to miss this episode. We were just talking before the show about COVID and the pregnancy COVID and pregnancy. Should you get the vaccine if you are pregnant? Dr. Bahnmiller has a lot of experience with that, and he will discuss his opinions on that. Many other topics too, testosterone for women, and does estrogen cause breast cancer? So you do not want to miss this show. Stay tuned until the very end so you can hear Dr. Bahnmiller speak on these subjects. So Dr. Bahnmiller, welcome to our show.
Thank you.
Yeah. So you're at Columbia Shores OBGYN in Richland. Tell me the history of how you started that. And I know you didn't start out in Tri-Cities, so tell me a little bit about your background.
Okay, well, I went to school in California, trained in New York, and made my way back to the Northwest. I'm from Montana. And then I practiced in Montana for a while and moved to Tri-Cities. Started practice here in 2007. I've been in this practice since then. And kind of working with doing mostly obstetrics and gynecology, and then recently we added a women's sexual health, which includes hormones and sexual function.
All right, so tell us a little bit about the women's sexual health and hormone part of it. Tell us a little bit about what women should expect from that.
What I did was, because it's practicing, came up to a lot of issues that it's like there wasn't a lot of resources or answers out there, and so kind of decided, okay, we needed to move out and find resources for this, because a lot of women have sexual dysfunction. If you look at the population, especially when you're looking at perimenopause or menopausal women, 40 to 60% have some sort of sexual dysfunction, and we look at it like, oh, that's normal. But it kind of got frustrating because a lot of women are like, what can I do? I don't want this to be my normal for the rest of life. And so started looking, and there wasn't a lot of resources around, and the resources you do find tend to overtreat or not treat from a good science-based or medical-based perspective. Like, I reached out to groups to say, okay, what can we do to help these women? There's one of the groups that one did a fellowship in was called International Society of Sexual Health of Women, a study of sexual health of women, and they're based out of Minnesota. But so I completed that just that way I could kind of. And they're a great group because rather than kind of just winging it and throwing things out there, it's like saying, okay, this stuff we know and we have good science and data behind to say, yeah, we're actually helping women. And a lot of it kind of even pushes the threshold with the FDA or the CDC, things like that you say, okay, we got to follow this. But they're like, no, we got to look at the real data. So I enjoyed being part of that. And then there's also what's called the North American Menopausal Society. And that's a group that basically focuses on hormones for women. And it's really saying, okay, even though the FDA doesn't approve testosterone for women, they have a big push for it because of the balance with that with estrogen. So it's kind of enjoyable because it's a little more challenging, and you just don't like see somebody say, oh, we got a carte blanche, give everybody this. You got to kind of tailor it for each patient what they enjoy.
So explain, when you say women's sexual health, what are some symptoms that you would see if women are having sexual dysfunction?
Well, the most common ones are going to be sexual desire. So a big thing that is that with women, a lot of times they feel like, well, I just have no desire because I'm busy, I have kids, I have a job, I got a lot of stress in my life, which is definitely contributing part. But there's a part of it too that's actually a medical and a very treatable thing, and we have fortunately more options than we did even 5-10 years ago. Other big thing would be pain during sexual intercourse, or just discomfort, pelvic pain, issues like that we use a lot of physical therapy, we use some medications, we use hormones, and just simple things to kind of help transition women to a healthy sexual life, which a lot of it ties in. The thing that's kind of exciting is that it really kind of makes you really work your brain when it comes to medicine, because then you're looking at, is it just sexual function? No, it entails both, like, obviously a general urinary system, and then you got your cardiology system, you got diabetes, you have a whole health, and you have to think about that, because that all plays a role in it. So somebody to have an optimal sexual life really has to have optimal health.
Correct. So Janet, do you have any specific questions about sexual health for women?
In our practice, we've heard some really wild recommendations. And so I feel like sometimes we've been shortchanged a little. I've had some clients express that their provider said, well, if you're having discomfort during sex at your age while you're going through menopause, let me prescribe some lidocaine for you. So do you use that type of treatment, or how would you approach that situation with a menopausal woman?
I mean, really the first step is to go, okay, what's the discomfort they're having? And then look at it from both, not just talk to them, think, oh, you have pain, let's just treat the symptom. We look at physically, obviously, on exam, see, okay, what's going on? Menopause symptoms cause a lot of changes in the skin, especially in the vulva, decrease in estrogen and testosterone, huge impact on that. The other thing we look at is, okay, psychologically, what kind of stresses, traumas have they gone through? And then you look at and do a detailed exam will tell you a lot, or just getting a good history from saying, okay, what's going on? Because not everybody's the same. And then if you just say, hey, let's just cut up the pain, well, are we really getting to what's causing it? And are we really helping the woman?
Well, you mentioned about testosterone for women. So how does that affect sexual health and affect the local symptoms that you might be talking about?
When you look at traditional method of treating somebody with pain intercourse, besides say pain medicines, the other thing a lot of times used is just straightforward topical estrogen, which is good. But the thing is that it needs to be balanced with testosterone, especially in the vaginal area called the vestibule. That's the area where you have predominantly most painful intercourse, and that's where you have a lot of pain receptors. Well, if you just give estrogen without testosterone, that area is very testosterone dependent. And so we need to basically complement the estrogen with testosterone. And usually testosterone is a 10-to-1 ratio of estrogen. So when you're thinking about it, you're like, oh, wait, why aren't we using this? Well, the thing is that one problem is that most doctors, most medical practitioners aren't taught that and we don't understand that. I mean, I didn't understand that until I delved into this more. Number two is that the FDA doesn't like to approve testosterone. Don't ask me why, but in women, they don't like testosterone. And so a lot of people get shy away from stuff that it doesn't have like the FDA stamp of approval, even though we use a lot of stuff, what we call off-label, and which is unfortunate for women, because when you use testosterone there appropriately, not overdoing it, you use it appropriately with estrogen, it makes a huge difference.
I agree 100%. I can tell you with our patients, testosterone, like for atrophic vaginitis, for vaginal atrophy, just the breakdown of that tissue, I don't think there is a better drug than testosterone to help for atrophy. I think, like you say, estrogen is great, but testosterone is even better. I think they work great together, just like you said.
Well, and just the basic science of it, when the body has testosterone, a good amount of that gets converted to estrogen. And if you look at take into like a broader role with our breast cancer patients, we actually will block the conversion of testosterone to estrogen just to create an estrogen-dependent breast cancer.
Correct. Right. We give them certain drugs to block that. That's for sure. So speaking of testosterone, what about the misuse of testosterone? You say testosterone is important for women. What about the misuse of testosterone for women? I get questions all the time. Am I going to get big muscles? Am I going to grow a beard? Am I going to get a deep voice? So how do you address that with your patients?
Well, I mean, obviously you may, because if you overly or inappropriately treat them with that, and which is kind of a concern, because when you look at it, it's not pushing for any kind of regulation, but when you look at testosterone, people are inappropriately prescribing it and not really one patient. Yes, testosterone is great medicine. I mean, and it's when I talk to patients, I say, okay, you have your estrogen, which is basically the symptoms you may notice the most are going to be hot flashes, or you're sleeping well because you're getting your temperature changes in your brain. So in the morning, you're going to just feel like you have brain fog, just like you haven't slept well, and you just feel like you're hungover. Estrogen's great for helping that. Testosterone is going to give you more of the vigor, more of the muscle energy, more just feel like you have good strength. And so that's kind of the differentiating as far as what women will tell you they feel. But so the problem comes in is that when you give testosterone, somebody starts to feel better. They start to have more energy, more strength. They feel like they can work out, and their sex drive increases because testosterone helps with that. The problem is that if you give them too much, they're going to feel great. Problem is, over that you won't notice the negative effects for a while. And so if you're continually having too high of dose, then you worry about problems with your, as far as your muscles, with your heart, with your lipids, and other issues too. So that's where it's important is like to work with you guys, and then with the lab and saying, okay, what things can we do to maintain and make sure this is there right? And what has to happen, you have to look at their blood work and say, we need a 10-to-1 ratio of this and estrogen, and they need to be balanced. We also follow what's called sex hormone binding. And this is what binds testosterone, and you have a little bit that's free. The reason we do that is because I look at like a teeter-totter. If you have too much estrogen, you're going to pull down your testosterone and vice versa. Mm-hmm. Well, if you balance it right, it should be good. If it's not balanced, you're going to get problems from estrogen, there's side effects there, and testosterone. But if it's balanced right, they should be healthy, and they should feel, like doing well. They're going to fix everything. But if it's like related to the hormones, it should balance out, and they should do well.
So speaking of balanced hormones, Janet has a question about estrogens.
So the fear that I hear from our clients, especially if they have a family history, is that estrogen is going to cause breast cancer. And so they're afraid to even approach hormones, or they've been told not to use hormones for the fear of just the fact that they're a woman and they're going through menopause, and you've reached menopause, now you don't need hormones anymore. So could you address those issues?
So estrogen got a bad rap. And if you look at estrogen is a good medication across the board. Now, is there times that you should not use it? Absolutely. But when we look at it, most of the negative results came from the 2002 Women's Health Initiative, where they did a big study, and they used a medication called Premarin and Provera, which Premarin is conjugated horse urine for estrogen. But and that kind of got a rap like, oh, what is that? And same with the progesterone. Now, is there better ones? Yes, I think there are. But the point is that at 2002, they stopped the study. If you look at the study, there's two big factors that really, they said, oh, we don't want to cause harm. And they were concerned about breast cancer risk increase and also heart disease, mainly heart attack risk. Well, first of all, we'll take the heart attack. Most of those women are approximately 15 years older than menopausal age, which means all of us are going to have some sort of heart disease. And they were given oral estrogen. The problem with that is two factors. They already have heart disease, so you give an oral estrogen. Estrogen, if you take it orally, it goes through your liver makes proteins that make your blood clot better. And what that does is that you get more clots. Well, if you already have blood vessels that are blocked off and you clot more, you're going to block off those vessels. So part of the issue there was that it was an oral estrogen and it was given later in life. So one of the best things you can do is do a topical, and then you bypass the liver and you don't have that problem. And usually you don't start somebody on it that's been off hormones for that long of a duration, then start them back on it. The second factor was with breast cancer, which a lot of women are more concerned about because that's kind of more highlighted. Breast cancer in that study alone was never shown to increase. Estrogen was never shown to increase statistically breast cancer. It never made it past the threshold. And then when they went back to the studies, that study reviewed that study, and then they did like the Nurses' Health study and multiple other ones. None of the studies ever showed an increase in breast cancer, even in patients that have a family history. Now, if somebody does not create breast cancer, now somebody gets breast cancer, are we going to keep giving estrogen? No. If it's estrogen dependent, we don't want to feed the breast cancer, but it does not create it. That's the difference. And then if you tear those studies down more, women that didn't have uteruses that don't need progesterone, estrogen had a tendency to even look like it may decrease breast cancer risk.
Well, and I think that helps a lot. Thank you for that. And I just want to add something to that is I think one of the biggest misnomers when it comes to hormone replacement is that we lump progesterone in the same category as medroxyprogesterone acetate. And if you look at the WHI study in 2002, that one arm that had conjugated equine estrogen, Premarin, and MPA, medroxyprogesterone acetate, you look at the side effects of medroxyprogesterone acetate, and it is a synthetic progestin. It is not progesterone, and they are created differently. And when you look at how they work in our bodies, they work differently. Medroxyprogesterone acetate works somewhat in the uterus, maybe like progesterone, but it doesn't work in the other tissues, like the breast tissue. It doesn't work in the brain tissue. It doesn't work in, like in our skin and things like that. So progesterone is very, very important, and it's important that it's progesterone and not synthetic progestins. They are not created equally. And here's what I usually educate patients on when I want to say how different they are. And I'll even talk to some doctors about this. Progesterone, what does it literally mean? Progesterone, support gestation. What is medroxyprogesterone acetate used for? Birth control. So that's how different they are. So we can't just think that the molecules are close and they're going to act similarly in the body. And if you look at progesterone actually has some anti-clotting effects. Makes a lot of sense, because if you look at the reason, a lot of things that estrogen does, progesterone does the opposite of in the body. So I think part of the issue with increased cardiovascular risk from that arm of the study was that they use MPA, medroxyprogesterone acetate, synthetic progestin, and not progesterone. Do you have any comments on that?
Well, actually, I'll kind of veer a little direction off of this, but kind of in the same vein, is I totally agree with that. And the interesting thing is that one thing I don't think most people are aware of, you said medroxyprogesterone used for birth control. A couple of reasons it's used for that. Number one, it's long acting. Number two, it's more androgenic than natural progesterone. And number three is that medroxyprogesterone is cheap to make. So those are the reasons that they're going to use it. The problem is now let's get back to sexual health. If you look at birth control pills, they're made with ethinyl and they're making with medroxyprogesterone. Some of the newer ones are coming out a little different combination, but the vast majority are made with that. The problem with that is that if you look at a typical woman, now most of them are teens, 20s, 30s, taking pills, those pills put them in tenfold menopausal state. So when let's go back to the pain during intercourse. The pain during intercourse, a lot of those patients, when I look at an exam, their vulva, their vaginal area looks the same as somebody that's been in menopause years. And it's like, well, that's the source of pain. And some of it's even reverse those effects. Well, on the rest of the body. I'm just saying something that's directly like, if you saw the difference, you'd be floored. And so what I'm saying is that sometimes we actually are causing more problems, harm than good. And when I look at, and that's the thing, it's not easy. And, it's like, okay, we need to figure out, okay, how do we help these women from birth control standpoint? Plus, how do we keep them healthy? And part of my philosophy, my theory, I guess you'd say, is that we may be causing a lot of like symptoms such as polycystic ovarian syndrome by messing with hormones.
Right. I totally agree with that, because with our first child, when I was pregnant, I had fibroids, and I'm sure that was from years of using the birth control pill. Because after we had our child and we had our second, there was no issue with fibroids. And I think part of that was because of balancing the estrogen with progesterone took away those fibroids. And, I think when you keep feeding it with estrogen, those problems just get worse. And, a lot of women, not all, but a lot of the women, when they are on the pill, their cycles are very small. There's not much there. So I agree with what you're saying. And it isn't just our sexual health too, because we had done just a scan. What was it? A DEX scan. And I had early signs of
Osteoporosis.
Osteoporosis. So, that was like in my 30s, and that to me is scary, because, you have that should be the highest point of my bone strength. So, definitely made some changes there, because, a fall in your 50s, 60s, and 70s can be very devastating to your lifestyle. So, I didn't want that path to continue as well, because, we always think it's just sex hormones, but it's also other parts of our body that are getting the message to do something that doesn't happen. And just being imbalanced hormonally with too much estrogen and not enough progesterone really set me up for some problems later in life.
Well, and the birth
That's a
control,
good point.
yeah,
Okay.
and the birth control pills can cause more than just those side effects. I mean, we get calls from providers all the time that somebody's on birth control pills and they're having all these sexual health symptoms, and they're having, or depression and many other side effects from birth control pills, and they want to balance their hormones. Well, I mean, honestly, the first step is really, you got to get them off birth control pills, because you really shouldn't be trying to prescribe something to overcome all the side effects of birth control pills. What are your thoughts on that?
Well, yeah, because that I think that's absolutely correct, because you cannot correct birth control pills adding something on top of it. I mean, the birth control is pretty potent, and if you're gonna stay on that, then you're just gonna, it's like you're chasing your tail. And it's frustrating, because then if you try to, even with bleeding, when they get breakthrough bleeding with that, and you try to chase with hormones, it's just frustrating, and it's tough to get them cycling, let alone what's going on in the rest of the body. And one of the interesting things is in sexual health, you're saying it affects other parts of the body, like depression, stuff like that. They actually did a study on women that were on birth control pills versus a population that wasn't. And they realized that in our brains, how we select out our mates, so our partners for life. And when you looked at women that were on birth control pills and when they weren't, they actually selected different partners. And they actually, not saying, oh, I'm choosing a riskier partner, but it changed the brain selection mode for how you choose a partner. The interesting thing is, then when they discontinued it, they noticed there's an increased risk of a rate of women breaking up with their current partner or divorce rate, which I found was interesting, because it's showing the dynamics of I don't think we give the brain enough credit for what it does, what happens, and the hormones, how they affect the brain, are substantial. I mean, I was
Wow,
just using that to kind of look it up. And when you
No,
talk about
that's
depression, you get to a whole new realm.
well, I think we shouldn't really be surprised. I mean, if you think of what birth control pills do, and they suppress sexual function, you're definitely going to choose a different partner than if you had vitality, correct? I mean, that just makes sense. Evolutionarily speaking, that makes sense. So thank you for
it
that.
makes sense. It makes sense from like just a pure pragmatic standpoint, but it actually has an effect on the brain chemistry, which I kind of was amazed at.
Yeah. Yeah. So we're kind of in some interesting times right now. So how has COVID affected your practice, in your clinic and in the hospital?
Well, as far as, I mean, it's kind of similar to the rest of the population. I think obstetrics is a little unique, because it has a little unique twist to medicine, because we're not just taking care of the patient, but then also her unborn baby. In a hospital, it's changed as far as the social demographics, as far as we don't have patients' families coming in. So it usually you have the patient, and then her husband is allowed to come in, or her partner is allowed to come in, and that's all. And then they're testing. So as far as the hospital, people worry, oh, is it worse? Well, it's actually, in my opinion, unless you're on a COVID floor, safer, because there's not a lot of people. You're not getting a lot of passage of things going on. So it's actually pretty clean, pretty, regimented. I don't see, like, say, oh, geez, don't go in and deliver your baby. I think actually it's better, and even good surgery. Patients are screened, and the population's actually, you don't get a lot of people there. The downside is, socially or psychologically, we don't have the family support, which is kind of nice in obstetrics. Which is kind of, before you used to have the whole family. Sometimes it gets a little bit crazy, but it's nice. And we don't have that, except for the mom and then her partner, which in a sense is nice, because it gives them a little more bonding time. When you move it out to the clinic, how's it impacted the clinical side? Yeah, it's increased dramatically stress, anxiety, high blood pressure, diabetes from the stress. So those factors have gone up. And then also too, we're quarantined, so we're sitting at home. So then we're less active. People don't go into labor as easily. You get more post dates or after you do dates that aren't going into labor. So you get increased rates of needing to do inductions or C-sections, which is like frustrating because unless you're active, the baby's not engaging, not going into labor naturally. Then the anxiety and stress of the patient with her baby, which is a legitimate concern, is like worried about, okay, is this going to affect the baby? And they say it makes us high risk. Well, as far as affecting the baby, the benefit for the baby is that they're inside the uterus, inside of the placenta, and the amniotic sac. Well, for something to get to the baby, it has to get through mom through the placenta to the baby, and mom first of all has to be exposed. So if mom's not exposed, no worry. Second, if mom gets exposed, there's not a significant number of receptors that will bind to the virus that the baby will get affected. So the rate of the baby being affected is extremely low. So it's not something like Zika virus where you're worried about, oh, you're going to have a high rate of anomalies. Or I find it interesting if people worry about that. I have a high number of teachers. Well, the teacher population, yes, you worry about exposure. You don't want to be exposed to any infection. Well, teachers are exposed to high rate of what's called cytomegalovirus or CMV. Cytomegalovirus is a common cold virus. You've lived with it for a long time. And so being around kids, you have a high rate of that. It doesn't mean that when you're pregnant, you're going to get no. Fortunately, we don't see it that often, but it's a cold virus and it happens. Most of them been exposed. Well, that is a higher concern to me than coronavirus for the baby, because the baby is actually essentially pretty safe with coronavirus. And then you look at, okay, when a baby's born, can they get affected? Yes. Children and young kids, except for we're starting to learn more about the mutation in England. Fortunately, it doesn't sound like it's significantly causing more harm, but it seems like it can be passed a little easier. May have a little bit more impact. We're not sure on that, but kids essentially are pretty safe, especially kids to kids transmission. Kids usually get it from their parents. But do we isolate the kids in a hospital? No, because especially if mom's breastfeeding, the baby's got antibodies from in utero and afterwards. So the baby's actually super safe. And the risk is super small. So babies are pretty good. Now the risk comes in because when you have somebody that's pregnant, and pregnancy in itself puts you at a higher health risk state. Well, the baby, when you're pregnant, even being exposed to any kind of sickness increase your risk. Like just the general flu or swine flu. So, and that's the same thing with coronavirus. If you get sick, worry about you dehydrate, put you in increased risk preterm labor, and those kind of issues. But not like it's saying, oh, this is significant risk. Yeah, it increased your risk because when you have coronavirus, you worry about respiratory problems. Pregnancy, you have increased swelling in the airway and stuff. So we treat it essentially the same as if you weren't pregnant. And most of the treatments can be used. Some of them are questionable, but that's like anything in pregnancy, and especially when we're treating something so new and abruptly. So, but the women do well with it. And yes, are there instances where there's some that are really sick and have a hard time? Absolutely. But that's just like the general population.
So now that we have a vaccine, doctor, I, as a female, and if I was pregnant, I would be really concerned as to what I should do. Because I feel as a pharmacist that we're not seeing that this vaccine has been studied for very long. It's came out really rapidly. And generally, what I felt when I was pregnant is that unless something was proven, I erred always on the caution side of not taking something because I just felt very conservatively that I didn't want to bring something into my body that was foreign and wasn't proven yet. What are your feelings about what a woman should do if she's pregnant? And, should she take a COVID vaccine? Should she take a flu vaccine? I mean, what are you recommending to your clients today?
Well, if you got, I would step back first to say, in a general population, like say my gynecology population, when they ask about the COVID vaccine. Now with COVID, the downside is that we've had to live with it for a short time, and it's been pretty abrupt on the population. The concern is that the vaccine, when you use a vaccine, understanding of it, the vaccine is not a cure. It's basically helping our immune system to recognize and to fight off an infection. So when we get a vaccine, it's using our body's own natural immune system. Well, from the best that we've understood so far is, okay, if you've gotten coronavirus, roughly it looks like about 90 days. I'm not sure, but it's kind of like we have 90 days immunity and then it starts to wane. Well, if you do a vaccine, the vaccine's utilizing your body's immune system. To say that it's going to last longer than that is hard to believe, because if our own body can't figure it out from the actual virus being in us, then what's the vaccine going to do? So it's like, okay, we don't know how long it's going to last, and from that, I'm just kind of relating it to that. We don't have any definite studies on that. The second thing is that when as far as rates of if you get infected, 98, 99% of the time you do well. Well, this vaccine will cover 95% of the time. So are we really covering that 1 to 2% that we're worried about not doing well? And should we carte blanche treat everybody with the vaccine, give everybody the vaccine, or should we select out the population, do a high-risk population, try to prevent it from spreading, and then maybe figure out, okay, at that point, do we then offer it to the general population? Those are questions to ask, to consider. Do I want to take a vaccine that we don't have a lot of data? Obviously, we don't have more than a year because the virus has only been with us roughly a year now. And so, that's the extent of what we understand of it. And the vaccine has been producing within that time. So we don't have a year, 2 years, 3 years, 5 years down the road what it's going to do to us. That's concerning. But then you carry that into the obstetrical population. And in obstetrics, we're always like trying to relate to what we know in the general population. And then we're also trying to say, okay, even more so, is the risk of the vaccine worth the benefit of preventing and protecting? And in pregnancy, unfortunately, I haven't seen where it says, oh yeah, there's definitely a benefit over the risk, because we don't know the full risk. And if we don't know it for the mom herself, how are we going to relate it to babies? And you'll read, okay, they say, well, the risk of coronavirus is worth the risk of the vaccine. It's like, well, what's the risk? And that's what I ask. It's like, okay, it's a plain, simple question. It's not saying, okay, if you told me, oh, the risk of the coronavirus, we kind of are getting an idea with that. But, is my baby going to be born with 2 heads? We don't know. Or what's that going to affect a baby later in life?
Well, so have you treated any patients of your OB patients that had COVID?
So as far as my patient, a fair number that have had COVID in my practice, fortunately, all of them done well, which I'm happy. I've treated some that were been sick that I cross-covered with other docs. I've been in the hospital, been hospitalized. Fortunately, none of the patients I've treated have not had to go to ICU. And I've taken care of a fair number of them that have been positive COVID. So, the ones that I've seen, now I'm talking to other colleagues, and fortunately, most of the pregnant women in the hospital, there hasn't been a significant number that have been extremely sick. There have been some, but the vast majority are healthy.
Does it seem to those ones that are sick? Did it seem they had any underlying like diabetes possibly, or were they older for being pregnant? Do you remember any of that?
It's kind of obviously the ones that have. There's been some that have had diabetes or obese, but to be honest with you, our pregnant populations become more and more high risk. And we've seen higher rates of obesity or diabetes, stuff like that. So for me to actually give an opinion, I couldn't really say, because I've seen both sides of it. I've seen ones that stayed healthy that are high risk. I've seen ones that are healthy, really sick, and vice versa.
Good. Thank you for that. That was a lot of good information. Yeah, I will tell you, Jen and I have been doing this podcast now for over a year, and we learned so much information from doctors like yourself. So thank you for being on today. So what about prenatal care? If there was one thing you could tell a pregnant mom to do for prenatal care, what would that be? I'm putting you on the spot.
Narrow it down to one thing.
Okay, two things.
I would say, I mean, there's a lot of things. The thing I think is probably the best is things that you can do to decrease your stress and anxiety. You know, I think walking, or just like, it doesn't have to be crazy exercise, and just some sort of activity usually makes a huge difference in stress, anxiety, high blood pressure, and keeps you healthy and helps you as far as at the end going to labor on your own without needing other alternative means. So I'd say exercise, obviously drinking lots of water and eating healthy, because those things, just doing simple things, I think makes a huge difference. And I think a lot of things that we end up treating are trying to undo or correct those.
Yeah, that makes sense. So what about vitamin supplementation? I know folic acid is important. Can you hit on that a little bit?
So folic acid is important. Folic acid is most important if you know you want to try to get pregnant. The reason I say that is because by the time you know you're pregnant, the benefit of folic acid is this: when you become pregnant, the major benefit that we know of is what's called the neural tube development and the neural tube closing. Well, that usually occurs by the time you get to 6 to 8 weeks out. Well, most women don't know they're pregnant until that point. So if you're thinking, there's a potential I might become pregnant, or I want to try to get pregnant, usually I say, well, it'd be nice if you could be taking this for a few months before. Folic acid is very important. The minimum is 400 micrograms. I like to do 800 micrograms. Now, some people have a deficiency called MTHFR. It's basically the enzyme in our body that converts folic acid and changes it to folate, reduces it. Well, folate's basically the active form in our body. Well, if you don't have the enzyme, or you may have one gene, not another, you're not going to make enough. So if you do L-methylfolate, which is basically you're taking a reduced form, so you're kind of bypassing that, is a nice thing. And if you have MTHFR, you should take that all your life. But so it's not bad to take that as opposed to taking folic acid.
Well, I'm a big believer in just taking, the methylcobalamin and L-methylfolate anyway. It might be a little more expensive in your vitamin supplement, but 57% of the population is, MTHFR deficient. So why not just take that? If you're going to take it in a multivitamin, you should just take it with those in there, is what I believe.
I agree.
Janet, do you have any comments on since you've been pregnant? Do you have any comments on that?
Well, yes, I guess one of the things that I stress with my ladies that talk to me or to younger women is that, being healthy before we have children is extremely important. I think those things are easier to get a hold of prior to becoming pregnant than it is being pregnant and then trying to, oh my gosh, I have gestational diabetes, or I have, different things, because we do have the ability to be healthier during pregnancy. So our outcomes during our pregnancy will be better, but also those lifestyle things that make us healthier also are going to affect our immune system, our bones, and how we bounce back from pregnancy. Because if you did have to have a C-section, there's another thing that takes away from your energy level and all those things. So anything that we can do to be healthy even before we get pregnant is something that I really promote for women, because I think we're short-sighted in our culture. We feel like, there's always the vitamin or the pill to snap us back, like blood pressure in a moment. But health is over time. And I've been seeing on Facebook this choose your hard. It's hard to do this, but it's hard to do that. And, being healthy from the very beginning makes it easier to transition into pregnancy, as well as delivering and raising your children. And so I think we owe it to ourselves. And if you're not sure what that is, find the tools to do that, because, just taking prenatals after you're pregnant, I agree. Sometimes we're missing the whole entire boat of prevention for the child as well as ourselves. So that's my 2 cents.
I think that's really good advice because I mean, so many times people come in and it's like you're like, okay, what can we do to kind of help keep you healthy when you're already at an unhealthy state? And it's simple things like you said. It's not anything crazy. It's just eating healthy and exercise and people think, oh, I got to go crazy. No, you don't. You just got to take time out. Go for a walk. Just do simple things and kind of get into a healthy mode. That'll help you through pregnancy, and that's what's going to help you after delivery. And actually, just one thing came to mind. It's like you're talking about L-methylfolate. One thing is too, like depression, anxiety, in pregnancy affects that. And so you'll see it come out in pregnancy, during pregnancy, especially right after delivery. One of the biggest times that's important is after delivery, you have a spike as far as postpartum depression and anxiety. And a lot of women think, oh, that's normal. I'm like, why am I connecting my baby? Well, that is important to be aware of. And if you notice it, to kind of contact your healthcare provider. But the other thing is too, that's where L-methylfolate has actually shown some benefit to decreasing, depression. And pregnancy is a perfect time for it because it's not like we're adding something that we're concerned about affecting the baby. It's something that's going to be good for both mom and baby and may help improve her depression to where she doesn't need something. But don't just depend on that. If it's significant, if it's starting to affect you, especially when you look at 2 weeks after delivery, that first 2 weeks we call it postpartum blues, which is common. But you shouldn't be having thoughts of hurting yourself or baby or things like that. If the blues go past 2 weeks, that's not normal. You should say, hey, I need help here. What kind of things can I do? Simple things like vitamins, medications, or counseling is important because if we keep you healthy, then you'll have a better time raising your child. You and your baby will do better, and your whole family relationship will be better.
Well, I'm going to interject. Some of the things that I think helped me the most was realizing there might be a time where, it's not wrong for a new mother to say, I need some help and step away for a moment, because that moment in time is just to regather your thoughts, your feeling, and because you're so attached to that child that when they cry, you want to help them and you want to take care of them. But sometimes we need to take care of ourselves in those moments and just have somebody else step in and help us, or even, put your child in a safe place and empty the garbage or something just for 5 minutes of peace and calm. Because, that anxiety and stress, I think, happens to all of us after pregnancy. Those hormones are, and everything in our body is just off the chart. And to me, I think sometimes as women, we always help, but we don't ask for help. And it could be just a few moments that you can step away. That's all you need to get back, into a good state of mind.
No, I totally agree. And I think our society's kind of gotten to the point where we think, oh, we have to be strong. We do this ourselves. But if you look back at human history, most of raising, you'd always be around families. Mm-hmm. You're always around, your siblings. You always have somebody. Now we're all like islands because, first of all, we're we move a lot, and so a lot of us don't even live near family. We, may not even know our neighbors, and so we kind of raise our families in little pods, and so it's basically depend on just, the parents, and that puts a lot of strain. And it's like we feel like we have to do it all ourselves, and which is really raising a kid. You need your support system. You need a support network, like you said, for somebody just to take the kids so you can go take a bath or take out the garbage. I mean, basic things become overwhelming. Mm-hmm. But when you have family or you have that support network, it's huge.
Yeah, that is for sure. So, Dr. Bahnmiller, we're winding our show down. I got to ask you, so what fires you up? What drives you? What do you have a passion for about what you're doing?
I don't know. In the obstetrics end, I don't get to see. I mean, I love to watch the development of babies because it's fascinating. I mean, if you can't get fascinated by that, you need a life.
That's right. That's right.
So true.
It is so true.
When they're born, and when their little feet and their little hands and their cheeks, I mean, they're just fun. Yeah, and so that's exciting. And to keep a mom, try to give them the healthiest pregnancy, and then when a kiddo comes out, just to them starting a new life and this kid in their life, that's exciting. So even though obstetrics beats you up because you got to be up all crazy hours. I feel like I'm a new dad permanently because I'm up every hour. But in the end, I mean, that's what drives me there is just the little kiddos. And then as far as in gynecology, sexual health, the reason it kind of like, I guess, I don't know if you call it double-edged sword, but one side drives me crazy when people are being treated and it's like, don't, and then they come into me and I'm like, what is this person doing? Because the thing is that sexual health is exciting because when you can get a healthy relationship with that woman and her partner, it's huge. And they're so much happier and it's like changes so much in their life. Just like a newborn kid does. Sexual health, if somebody's healthy, then they're going to have a healthy sexual life. If they're not healthy, it's tough to have a good sexual life. I mean, things just don't work right and the saying in my arena is that your brain is your largest sex organ. Those guys will disagree, but that has a huge impact. And to keep your brain healthy involves a lot of things, from just general health, diabetes, heart health, to hormones and stuff like that. And when you see a happy couple, that is rewarding, because you go from them feeling like, oh, this is our new standard of life where we aren't intimate. And intimate isn't just sex. I mean, it's intimacy, closeness, things like that. And when you can have that's rewarding.
Yes, that is. And it is very rewarding when you, balance somebody's hormones. And a lot of times from what we see is women get their hormones balanced, and next thing you know, their husband has to get their hormones balanced. And that is very rewarding because,
or Shawn
and
gets the call,
yeah,
hey,
we,
we need to talk.
yeah, we warn them all the time. It's like, hey, your husband is going to probably need to go in and get something done too. So, and it's very rewarding because sexual health is very important in our lives. And like you say, it is part of health. I mean, so healthy brains, healthy bodies, healthy sex life. I mean, that is very
Well,
important.
healthy relationships as a whole, because if mom is happy, or the wife and the spouse are happy, the home is happy, or the relationships are happy, and I mean, we can just keep expanding. But I think that starts with just small steps to feel better about life. And so this is one thing that gets overlooked and also maybe mishandled some. So it's great that there's a provider out there that people can go to address this, because sometimes it's very uncomfortable. Who can I talk to about this with?
Well, and I think piggybacking on that too, age doesn't matter.
Mm-mm.
Also, I know patients in their late 80s, early 90s, and they still have an active sex life, and they say they don't want to not have that. And so it is concerning to me when some doctors will say, oh, as you age, you just don't want to have sex as much. I think that's a problem, because that might not be the case, necessarily have to be the case.
But I completely agree, because if you look at it, women that don't feel like they have desire feel less sexually attractive, less healthy. So the impact, and they are more depressed and more anxious. And so really, in order just to give them the feel like, oh wait, I have a desire. They love their spouse. They want to have close, intimate relationships, but if they don't have the desire, they feel like it. And some people part of the studies show, okay, they don't feel sexy or attractive, that decreases desire. But on the other hand, too, one thing that's interesting in studies, they show that actually, if you don't have desire, you don't feel attractive as well.
Right,
And
that makes sense.
the other part of the treatment is that the men, and which there are twofold to that, or this partner. If a lot of times I'll have women come in, they're like, well, my husband, it's like the first couple of visits about her. Next thing you know, I'm answering questions about him and trying to figure out, okay, where do we get you resources? Because a lot of it too is like, you get the woman better, and all of a sudden now she's like, okay, but he needs some help too.
Right,
And
absolutely.
the fact is, like you take painful intercourse, I think a lot of these women, you first of all say, oh, women feels bad because it hurts and she doesn't want to have sex. A lot of women will have sex when it's painful, but the husband doesn't want to hurt the woman. And that's what the studies show. So they'll actually pull back more and feel distant, and then start that impacts relationship, lose that closeness.
Right, for sure.
So,
Well, thank you for being on today, Dr. Bahnmiller. That's a lot of great information. Our listeners and viewers got a lot out of that. And as always, you can catch us at 1 to 2 p.m. every Monday, streaming live on my personal Facebook page and the Moses Lake Professional Pharmacy YouTube site. And Wednesday, we are going to have in our midweek podcast, which is normally Thursday, we're going to have James Donovan. He has been doing the carnivore diet for 1 year now, eating exclusively carnivore, and he's going to show us his numbers. And he has lost weight. He's going to show us his other blood chemistries and such, so we can see how the carnivore diet has affected his lab report. And Monday, do not miss out on Monday's episode, 1 to 2 p.m. We will have Dr. and Senator Scott Jensen from Minnesota. He's been on our show before. He's been on Fox News multiple times. He's been on Rush Limbaugh's show. He is going to go in depth about the coronavirus vaccine, so you do not want to miss that show next Monday, 1 to 2 p.m. Dr. Bahnmiller, thank you so much for your expertise and being on our show today. We really appreciate you having on. And you've been listening to Health Solutions. You're welcome. You've been listening to Health Solutions with Shawn and Janet Needham. Tune in Wednesday, 8 to 9 p.m., 8 to 9 a.m. Thank you so much for listening.